Okay, well, let's get started. Today will be the second of 3 presentations related to exam number 3. Last time we took a look at the skeletal system. We looked at bones and histology of bone. We looked a little bit about how bones repair themselves. Today we'll be looking at Chapter 8, which is dealing with joints. We'll also look at fractures and arthritis and a few other issues related to joints. And then on Tuesday of next week, we'll be focusing on muscle. Although it's 5 chapters in your book, it's only three presentations that are on this next test. 2 of the chapters in those 5 are actually like atlases, like name all the bones and name all the muscles. And so I'm not going to be lecturing on those chapters specifically. On mastering, you'll find 3 homework assignments. One is labeled as chapters 6 and 7 together. That's bones. 8 is joints. And then 9, is that right? 6 and 7. 8 is joints, and then 9 and 10 are muscle. Okay. You'll also find on mastering a quiz that'll be due the night before the next exam, so a week from last night at midnight. And there also is a quiz on there regarding the lab exam. So there are 5 assignments on mastering, 3 homework, 1 quiz for the lecture, and 1 quiz for the lab exam to help you get ready for those things.
And then the modules are just practice.
The modules are just practice. Again, just like before, those are just there. Some people said they liked them. Great, they're there for you. If you don't like them, they're not required. I don't have control over the content on those. It's like an all or none kind of thing. And some of the questions may not be directly pertaining to what we've done here. If we haven't discussed it, it won't be on the exam. Okay, so don't worry about it. If you come across a content or a question that deals with things we have not discussed, it is not something you need to worry about. As I go through today's presentation, you're only focusing on the same muscles and bone markings that we've already seen in lab. So we're not adding to your list, we're just going to confirm that list and keep talking through the same structures. Also on that exam next Thursday will be vocabulary 38 through 52. I think it's the right numbers, 38 through 52. And let me go through a couple of the, 37 through 52. So let me go through those with you now, or a few more of them, and then we'll get into the next chapter. Are there any questions or concerns, logistical things? Yes, ma'am?
Can you repeat those chapters again?
This is going to be 6 through 10. Okay, 6 through 10. 6 is about bone. 7 is a chapter in your book that says it's like all the bone structures, right? I'm not going to lecture on that. 8 is on joints, 9 is on muscles, and 10 is name that muscle. So it looks like a lot more than it really is, and but 3 lectures. Okay, does that make sense?
Yeah. Thank you.
Sure. Now keep in mind that as you're practicing or studying for this lecture exam, you're also studying for the lab exam, because a large part of the lab exam does cover muscles, bones, and bone markings and joints. And so it's the same content. You're going to be quizzed on it twice, essentially. Vocabulary, let's pick up here with 45. And there's some really, really highly used prefixes on this subset. You had hyper and hypo, and now we've got intra, right? Very, very big one. Intra means within. So intracellular, right, within the cell, inside the cell. Iris is the colored muscle of your eye. It means rainbow. And ism, condition or state. Isthmus, the greatest. So we've seen the latissimus dorsi. We know it's a big, great muscle of the back. And iso, we saw isotonic a long time ago. And we'll see isometric next time, same or equal when it comes to iso. Ite. Little. When we get to the nervous system, we'll see dendrites. Dend, you know, means tree. So dendrites are little trees, little tree-like branches coming off from the neuron cells. Itis, inflammation. Arthritis, inflammation of a joint. You name it, any kind of arthritis. Neuritis, inflammation of a nerve. Im and in are both negating terms, just meaning not, and immunoresistant. So think immunology is a study of how your body stays resistant to diseases. It's a good thing we have the study of immunology with Ebola in our nation, right? Juxta, near. We'll see a lot of terms juxta later on. Cal, K-A-L. Cal, right, is calcium, but Kal is potassium. So K is the single chemical identifier for potassium. Hyperkalemia, right, would be high levels of potassium in the blood, which, if we were talking about high levels of calcium, it would be hypercalcemia, right? So they're close. They sound similar. Karyo or kary, the nucleus. We are eukaryotes. We have a true nucleus. Remember, EU means good or well. So eukaryotes have a true or a good nucleus. And carot, cornea. Keratitis would be inflammation of the cornea. A keratotomy would be a cutting of the cornea, basically what's done with LASIK surgery. And we'll finish up, we'll do 2 more today. So kyph, last lecture, last slide of that last presentation, we saw scoliosis, lordosis, and kyphosis. And kyphosis was that hunchback or that humpback look that is a curvature of the thoracic vertebra. Labi, or labi, meaning lip. Lacera, if you have a laceration, you have a tear or a cut. And lacrimal, you've seen the lacrimal bone. It's right there by the tear ducts. Your lacrimal gland are your tear-producing glands, and they drain into the lacrimal duct right there at the base of the lacrimal bone. Lacto, milk sugar. Lactose is milk sugar. Lacto refers to milk. Lamina, laminated, layer. Think lamella, lamina. Lapar, abdomen. If you have something done laparoscopically, they are putting a hole in your abdomen and they're looking in there and doing surgery without having to open you up too big. Lati, broad. So latissimus dorsi, right? The broadest, biggest muscle of the back. And I'll stop there, and that will only leave us with 3 slides to do next time. And as you pointed out to me, your 52 goes through lunar. So somewhere I got off by a termer here, but we'll go through lunar, right? Because that's what yours number 52 has, right? So we'll finish up with that for the exam next Thursday. I think this vocabulary should go really, really well, but you've got to keep infra and inter and infra, right? Keep those straight. They're similar, but they're also highly, highly used prefixes. So make sure you're very familiar with these prefixes. Moving on now. This is your chapter 8. I'm going to get my numbers updated. And before I get going on this, some of this you've already seen in lab, but are there any questions or concerns about anything covered in the last presentation on bone or the skeletal system? Anything at all to clarify? Yes, ma'am?
I thought this was chapter 7.
No, 7 is that name that bone chapter, right? So 6 is about skeletal system. 7 in your book is bones, just name them. And then 8 goes on to be joints.
So for the PowerPoint, it's chapter 8.
Yes. Yep. So in lab, you should have heard about 3 different types of structural joints, right? A joint is where 2 bones come together, and most of our joints are freely moving. They allow our skeleton to move around quite a bit. However, there's a couple of other special types of joints. The one is fibrous joints. Now, this is where 2 bones come together, but there's little to no movement. And there's 3 examples here. Number 1, sutures. Now, which suture do you need to know for lab? You need to know the coronal suture, right? It's the suture that connects the frontal bone to the 2 parietal bones. And you recognize that that bone's not wiggling, right? It's not moving. It is a joint. It's where 2 bones come together, but it's not meant to wiggle. So that is a fibrous joint. Then there are what's called syndesmoses. Now, when you look at the skeleton in the lab, and you see the tibia sitting next to the fibula, you just kind of imagine these 2 bones are sitting there side by side. Or in your forearm, the ulna and the radius, right? They're not just hanging out side by side. They are attached to each other. Now, what attaches a bone to a bone? What kind of structure? Bones are connected to other bones through ligaments, right? So at the distal end, for example, of your ulna and your radius, there is a ligament that connects those two bones together. Now, it's not meant to be a movement kind of joint, but it is more of a stabilizing type of joint. So again, it's a fibrous joint. Little to no movement, but the bones certainly are connected one to another. And then there's a special type called gomphosis. This is, I always think of gum phosis. This is the interaction between your tooth and your maxilla or your mandible. So as the tooth fits into the socket, it's held in place. Your teeth shouldn't be wiggling, right? So normal dentition, healthy dentition, your teeth should not be wiggling. That's also a fibrous joint. So just to get a visual of this, you can see here that the sutures come together, and here it's not even cartilage, right? It's not even the same kind of cartilage we would expect to see in a bone. It's actually dense connective tissue that glues those bones together in the sutures. And then here is that ligament, as an example, that's connecting the tibia to the fibula. Again, at the distal end, those bones are being held together by a ligament, and that's that syndesmosis word, where it's a stabilizing joint. Then the cartilaginous joints. Now, these are where two bones come together, but they are connected only through a large chunk of cartilage. The three examples here. When the ribs come around and connect to the sternum, they're only connected through a big chunk of cartilage. We call that cartilage the costal cartilage, the rib cartilage. There's also, as your vertebrae stack, right? You know that the bodies of your vertebrae are stacking, and in between each of the bodies is a intervertebral disc. That disc is a chunk of cartilage. So the discs are a good example of cartilaginous joints. And then the one that's not listed here is your symphysis pubis or your pubic symphysis. That's where the two pubic bones come together. You know that bone marking, or you're learning it. It's where the two pubic bones grow together, and there's a big chunk of cartilage there as well. So that's another example of a cartilaginous joint. Now, the rest of the joints in your body are synovial joints, and that means that they are pretty much a freely moving joint. Remember we talked about membranes, the end of chapter 3. I mentioned that there was cutaneous membrane, serous membranes, mucous membranes, and synovial membranes. And membrane there meant this cavity, this space around your synovial joints where there's fluid. So your joints, most of them have this synovial fluid and a synovial membrane holding this fluid into its place. And these joints come in 6 different varieties. In lab, right, you only need to know 3 and the same 3 here. I only want you to worry about hinge joints, pivot joints, and ball and socket joints. The other ones I'll show you briefly, but I'm not going to ask you anything specifically about them. So when I say hinge joints, what comes to mind? 2 hinge joints. Elbow and knee, right? Nothing to imagine, difficult to imagine. The word I want you to think about, though, for a hinge joint is that they are uniaxial. They're only moving in one axis, X, Y, or Z. Versus pivot. A pivot joint, and the pivot joint I want you to specifically think about is going to be the atlantoaxial joint. That is where your atlas, C1, and axis, C2, come together. And because of that interaction of C1 and C2, you're able to say no, right? You can nod your head back and forth, and your head is literally twisting on that little pivot of the dens that we'll talk about in a second. And then lastly, the ball and socket joints, shoulder and hip, right? The anatomical names for those joints will be coxal and glenohumeral. And we know coxa means hip, so we'll call it anatomically the coxal joint. And then there is the glenohumeral joint. Now, the ball and socket joints are multi-axial in that you have tremendous mobility, tremendous movement in many directions of both your glenohumeral and coxal joints. Now, the other 3, when it comes to planar, also called gliding joints, or the condyloid or the saddle joints, I'm not going to ask you specifically anything about those. I'll show you a picture of those in a moment. I do want you, however, to at least recognize, if I said, where's your metacarpophalangeal joint? Right, where would you go? So metacarpal, phalangeal, fingers, so that would really be your knuckles, right? Metacarpophalangeal joints. And if I said your intercarpal joints, inter means between, So intercarpal joints would be the joints or the spaces found between those carpal bones. Or if I said carpo-metacarpal, right? Carpo-metacarpal, that would be really kind of your wrist, wouldn't it? Okay, so just appreciate where those are, but no specifics. Oops. So every time I see a bone marking, I'm going to point it out. And I know that many of you are still becoming familiar with your bone markings, but I know too that repetition is key here. So the more times I say these things. So as I look here as an example of a hinge joint, right? I see, for example, the elbow, and I want you to tell me every bone marking that you see here. The tip of the elbow, the olecranon, okay, the tip of the elbow. And right here, this is the round part of the radius. That would be called the head of the radius. There's a structure, a roughened surface on the radius to which the biceps brachii muscle inserts. That would be the radial tuberosity. The ulna has that letter U in it. That letter U is called the trochlear notch. And the trochlear notch of the ulna fits into that pulley-like structure called the trochlea of the humerus. Lastly, the head of the radius is going to fit on this rounded end of the humerus called the capitulum. Okay? So the capitulum goes to the head of the radius. The ulnar notch of the ulna goes to the trochlear notch of the ulna goes to the trochlea. Okay? So I'm just going to keep knocking out these and mentioning them to you as much as I can. Looking at an example of a pivot joint. This is the atlantoaxial joint. You're looking at it. What you're seeing is C2, right? The axis C2 and the atlas C1. And what we lose perspective of in the lab is that there is a ligament that is going to kind of hold all this together. And these two bones are going to pivot. And not only are they going to pivot, but the whole skull is going to pivot, isn't it? The whole skull is going to pivot on this little structure. This little tooth-like structure right here that's on the axis is called the dens. Okay, now the other name for that is the odontoid process, the tooth-shaped process. Remember, in bone world, anything that sticks out is a process. So the dens or the odontoid process. Now, what is going to rest on this cartilage? What is going to rest down on the cartilage of C1? The occipital condyles. Beautiful. Those bumps on either side of the foramen magnum. This little opening right here. That opening, it's on a cervical vertebra, C1. So that would be the transverse foramen or transverse foramina. I'm getting some looks, right? I don't know this yet. You will. You'll learn this. Okay. Now, these are the examples of planar, saddle, and condyloid. And I told you I'm not going to ask you specifically about these, so don't worry about these. I just want you to realize that all of these other synovial joint types are well represented within the hand and in the wrist. So the saddle, the condyloid, the gliding joints, there are representatives of them in your wrists and in your metacarpal phalangeal joints. I'm not going to ask you specifically, just kind of know, okay, the hand is where I would go to find those. Then finally there's the ball and socket, and this one I want you to know more about. So the ball and socket, as well as the shoulder, here we've got the hip or the coxal joint, and there's some beautiful bone markings here that I need to ask you about. So let's go through a few of these. So on the os coxa, right, which is this bone, this is the os coxa when it's all together. And we know that this is a combination of the ilium, and this bone is the pubis, right? The portion of the os coccygis of the pubis, and right now you're sitting on your itchy ischium, right? The ischium. Now, what is it? What's this bone marking right here? This piece of cartilage, it's a cartilaginous joint, is representative of what bone marking? Yeah, the pubic symphysis or the symphysis pubis. You'll see it written both ways, right? The other hip is right over, the other os coccygis is right there. What is this opening? Obturator foramen. Obturator foramen. The openings on the sacrum, dorsal sacral foramina. The top of the ilium, iliac crest. Yeah, there we go. This big bump on the femur, greater trochanter. This button on the lesser trochanter. The rounded portion of the femur is called the head. The narrow region is the neck. The head of the femur is fitting into a socket structure called the acetabulum. Very good. Very good. Now, we pay a price, right? The shoulder and the hip are coxal and the glenohumeral joint. They are very mobile, right? And with that mobility comes a lack of structural integrity, or at least a weaker joint. And so this just shows that inverse relationship. The most movable or the most mobile of your joints is your glenohumeral joint. Or your shoulder can do some amazing things. Remember, this is a multi-axial joint. Tremendous movement, but with that tremendous movement, it's rather unstable, right? So this is the bread and butter of a physical therapist, right? This is they're going to see a lot of people with shoulder issues. They're also going to see a lot of people with hip issues. So the coxal joint is also a pretty freely moving joint, not quite as much as the shoulder. Keep in mind, this joint has to maintain the weight of your body. So there's a more substantial structure here. You've got that head fitting into the deep acetabulum. So it's a little bit more stable, a little bit less mobile. The elbow is kind of right in the middle. The intervertebral discs certainly don't move around too much, so they're pretty stable. And then, of course, most stable of all, but also immovable, are essentially your sutures. Right? So we see this inverse relationship between mobility and stability. Now in lab, there were some different motions that I asked you to know. There are gliding surfaces, and I'm not going to ask you about any gliding surfaces, but even, for example, your little carpal bones, they're gliding, they're sliding over each other, they're moving. The 7 I wanted you to know from lab are all angular type movements, and they come sort of in opposites. So you have abduction and adduction. You know from the vocabulary that AB means away from, and duct means to lead or to draw. So abduction is to lead or draw the body or some part of the body away from the midline. So I could raise my shoulder. That would be abducting my shoulder or my arm. I could separate my fingers. That would be abduction of my fingers. Adduction is bringing everything back to the midline, bringing it back basically to anatomic position. Then we've got flexion. Flexion, we know flexing the biceps brachii. Flexion is to decrease the angle. Extension is to return that angle back to 180 degrees. And hyperextension is to go beyond 180 degrees. Lateral flexion, just simply bending to the side, right? Lateral side, flexion, decreasing the angle, and then you've got circumduction as well. Those are the 7 that you've already seen in lab, and you've already seen this image, or these images, or something like it, right? So abduct and adduct, you can do this with fingers, with arms, with legs, all sorts of things if you're moving away from or toward the body's midline. I would never want to hyperextend my knee, but I can certainly hyperextend my wrist as an example. So flexion, right, bending, decreasing the angle, thus flexing the wrist. Extension would be bringing it back out to 180 degrees. And then to hyperextend would to be to increase this angle beyond 180 degrees. So I can easily hyperextend my wrist. I can hyperextend my neck by looking up, but I wouldn't want to do that to some other joints. Circumduction, just keep the proximal end of a finger or an arm stable and swing the distal end around. Keep in mind, all of your circumduction would be done with appendicular bones, wouldn't they? Your long bones. And that's always going to have distal and proximal associated with those long bones. Now, there are some other movements that I did not describe in lab, and they are as follows. Well, actually, this one you know as well. I told you pivot. Right? I want you to know pivot. Another name for pivot would be rotational. So you're rotating that joint. The other ones, though, that are special or kind of unique are depression and elevation. I've got pictures of each of these coming up. Depression would be any inferior movement of the body. Just imagine dropping your shoulders down, right? Just kind of shrugging your, not shrugging, but just dropping your shoulders down. That would be a inferior movement of the body. The opposite of that would be to elevate. So to shrug your shoulders up would be to elevate, right? Pretty easy. Then there is dorsiflexion and plantar flexion. These two are dealing with the ankle. Dorsiflexion is lifting up your foot such that your toes are going toward your knee, right? So kind of flex your foot up. That's dorsiflexion. And then to do toe point, that is plantar flexion. And I'll show you pictures of these. We've also got eversion and inversion. This is turning the inside of the foot either inward or outward. Pronation and supination. Let me take a moment to describe this a little bit better. Supination, well, first of all, in your anatomic position, the ulna and the radius are parallel. Right? We've seen that the ulna and the radius are parallel. Pronation is the movement such that, so pronation is rotating the forearm such that the palms go backwards. And as the palms go backwards, the radius and the ulna crisscross. Right? So as one pronates their arm, the ulna crosses over the radius. Now when I bring the palms back around to anatomic position, now the ulna and the radius are going to be parallel again. That movement of bringing my palms back forward is supination, to supinate. The way I remember it, for me to reach my supper, right, I need to have my palms forward, right? So as I'm going to bring my palms forward, that motion is supination. To put them back would be pronation. But that's what the notation means as far as the crossing over. So as I supinate, right, as I do supination, at that point, the ulna will once again be parallel, right? The ulna will be parallel to the radius. That's what the notation means. I'm back in anatomic position. Retraction to, protraction first. Protraction would be any sort of movement that is going out from the body. So you sticking your lower jaw out. You just kind of stick your jaw out. That would be some sort of protraction. To bring it back would be retraction. They're just opposites. And then there's opposition. We are said to have opposable thumbs. We have the ability of taking our thumb and putting it over our palm. This is something that some other primate-type animals cannot do. So we're distinct in the animal kingdom in that we have opposable thumbs, and other lower apes and whatnot cannot do that. So let's take a look at these motions. Rotation. This is the one I want you to know, right? As you are rotating or pivoting your head, what joint is being used right here? As I rotate the head, as you say no, you are rotating your skull on the atlantoaxial joint, right? That joint of C1 and C2. Yes, you can rotate all sorts of things. You can rotate your arm and your leg, all sorts of things. And most of those rotational movements are coming from the ball and socket, right? So as I do this, as I twist my elbow around, or if I were to twist my hip, my leg, it's really that rotation is coming from the ball and socket joints. Then depression, just kind of lowering your shoulders and then bringing them back up to elevate. Dorsiflexion would be, again, taking your toes and bringing them up toward your knee. whereas plantar flexion is doing toe point. And inversion and eversion, simply turning the inside of the foot. This shows the motion of supination. So the motion of supination is to, again, bring the palms forward to grab supper, and in doing so, the ulna and the radius become parallel. To pronate is to flip the hand back around, and now the ulna and the radius will crisscross. Protract, stick the chin out. Retract, bring it back. Opposition, thumb across hand. And then I didn't have this one on the list, but to bring it back is to reposition, right? So opposition, reposition, opposition, reposition. So just know those little movements. Now, in days gone by, when I taught at schools with smaller classes, I used to have students go out in the hallway and demonstrate these different motions for me. So I used to have about 12 different index cards, and I'd turn them all upside down, and then the students would come out in the hallway and just randomly turn over 4 of them. And I'd say, okay, demonstrate that movement for me. And I would just check off, okay, you got it. I don't have time for that, honestly, in this big of a group. So what I'll do is more describe these motions. So if on the test it said a person raised their arm and put it on the back of the couch, right, which of the following motions has just been demonstrated? So if I raise my arm to put my arm on the back of the couch, what have I done with my arm? Well, of the choices, abduct, right? Abduction, right? Or let's say I'm going to take my palm and I'm going to tighten my finger so I can catch some water, right, to drink out of my hand. I'm bringing my fingers inward, so that would be adduction, right? So that'll be the way I'll quiz you on this. It'll be more of a description of a body motion and which of those would be correct. Now, the next 20 or so slides are really more of a kick back and appreciate what I'm about to say. There's a lot more here than what you'll need to know. I'm going to go through about 6 or 7 different joints in your body. What I want you to know as we're going through this is, number one, and these are all synovial joints that I'm going through right now, what bones are involved, right? So when I say TMJ, this is the temporomandibular joint. It's going to be between your temporal bone and your mandible. And I want you to know what where the joint is and what bones are involved. And as I'm going through this, I'm also going to highlight and point out all of the bone markings that I can possibly see related to this. There will also be a lot of ligaments. I'm not going to ask you about ligaments. There's no ligament anywhere on our list, okay? Ligaments are what hold bone to bone together. But I want you to see this complexity of these joint spaces, and as we're looking at this, I'll point out those structures that I do want you to be responsible for. Now, this very, very first word that we see, we're going to see on every one of these slides, diarthrosis, and all that means is that this is a freely moving joint. Right? So these are freely moving. They're not fibrous, they're not cartilaginous, they're freely moving synovial joints. Now the TMJ is a coming together of the mandible and the temporal bone. We did not learn the mandibular condyle. We did not learn the mandibular fossa, so you don't need to know them. So my point is I'm only going to quiz you on the same bone markings that we had in lab, not adding to your list. This is actually 2 joints built together. This is your chewing joint. This is the bread and butter of a orofacial surgeon, right? This is where a lot of problems are because, again, this is such a loose joint. There's a lot of problems. When you chew, you don't only move up and down, right? You also move side to side. So all that movement creates a less stable joint space. Okay, so this is, again, there's a lot of different types of movements going on in the TMJ. Now let's take a look at it just to get an idea of where we are. And again, I'll point out any and all bone markings that we need to know. One of them is marked here for us. So let's get our bearings. This is part of the mandible here, and this is the temporal bone up here. This little guy right here, right, this little saber-toothed tiger guy, that's the styloid process on the temporal bone. And what would this be? Mastoid process, good. What muscle attaches to that mastoid process? Sternocleidomastoid, right? It tells us in the name, mastoid. And what is this opening? External auditory or the external acoustic meatus. What we see here is that there's really two joints, and you know that because this blue area is fluid-filled synovial fluid, right? So there's your synovial fluid in the joint. The bones are going to have on their edge hyaline cartilage. That articulating cartilage is going to be at all of the joint surfaces, allowing bones to slide over each other nice and smoothly. And you can see there's actually two joints built into one here. I'm not going to ask you to dissect this, but you can see that there's two, if you will, synovial spaces there, and they have different jobs. Let's look at it from a different view. And now you can appreciate, right, that you can't even see where the two bones come together, because every time we look at this as a common theme, you're going to see that they all have ligaments, right, attaching and holding these joint spaces together. And we lose that perspective in the lab because we just see bones hanging loosely from each other. You can even see that the styloid process has its own little ligament that attaches to it. Now, next semester in Biology 106, we will name many, or not all, but more of these ligaments. The good news is ligaments name themselves. Right? I'm not going to ask you to know them this semester, but look at this one. It's called the stylomandibular ligament. Oh, it must be a ligament that attaches the styloid process of the temporal bone down to the mandible. Or here's one, sphenomandibular, right? And it's going to go from, actually from the mandible up to a portion of the sphenoid bone. So you're going to see that they're not difficult to name at all. Let me quiz you on a couple more things here. What is this bone? Zygomatic. This bone? Sphenoid, right? And this bone is the temporal. Next, let's take a look at the glenohumeral joint. It is a freely moving joint, the most freely moving joint. It is, as you know, a ball and socket joint that connects the head of the humerus, so these you know, the head of the humerus with the glenoid cavity of the scapula, and that's where it gets its name, glenohumeral. What we don't see, and what we're not going to see this semester, is that there are some rotator cuff muscles. You've probably heard of them, but there's rotator cuff muscles deeper in the shoulder that are going to hold this structure together and give it its incredible strength. There's something new here that I do want you to know, and that is there are bursa. Now, in our vocabulary list, back on test 1, burse meant purse. And you're like, okay, I'll learn that. I want you to think of these bursa as sort of being like gel packs. They're like fluid-filled gel packs. And they're going to protect and give more structural integrity and protection to the joints. And I'll show you a bursa in a moment. So here is a picture of the glenohumeral joint. You can't even see the humerus, right, the head of the humerus. You can't see where they're articulating because, again, there's all these ligaments that are giving structure to this joint. The blue is the bursa. So it's called the subdeltoid bursa because it must be under what muscle? Sure enough, right? Not that difficult, right? The subdeltoid bursa, there it is. It's this gel pack or this fluid-filled gel pack. We can see the clavicle. And as far as the scapula goes, this is the coracoid process, and this would be the acromion process, the true tip of your shoulder. If we look at it straight on from the side, okay, we're looking at the shoulder from the lateral view. This cartilage right here would be sitting on the inside of what part of the scapula? What do we call this space where the humerus fits into the scapula? The glenoid cavity. So this would be the cartilage on which the head of the humerus is going to rest and twist, okay? We can see that there are these bursa all around, fluid-filled gel packs. And you can also see that there are ligaments and tendons that are up in here. Now, if you go back and you look at the origin and insertion worksheet, right, there are 6 muscles that you need to know more about for the lab practical. The sternocleidomastoid, the biceps and triceps brachii, the rectus and biceps femoris, and the gastrocnemius. And if you look carefully at that description of the biceps brachii, you will see mentioned that one of the tendons for the biceps brachii goes up into the shoulder area and attaches up to the coracoid process in the glenoid cavity. Right? You'll see that mentioned specifically. So here we can see that tendon coming up, and it's this one right here, right? And it's attaching right here in this glenoid cavity by the coracoid process. Let's look at it from a different angle altogether again. Now we're looking at more of a coronal section where we're looking into the joint, and this is the acromion process at the top. And again, here's the acromion, and here is that biceps brachii tendon coming in and attaching into this whole space. The blue is the bursa, and the purple here would be the synovial space where the fluid would be, and then you see white lining all of the articulating surfaces. Radiocarpal. Radiocarpal. So this would be your wrist. Again, it's a freely moving joint, diarthrosis. It's actually 3 of your carpal bones. We didn't name them, so don't worry about which ones. 3 of your carpal bones coming in direct contact with your radius. The ulna is actually not directly attached. You'll see in a moment that the ulna is a little bit removed from your wrist. Now, the wrist has a lot of motion in it. I mean, you can flex your wrist around and do all sorts of things, but it's certainly not the same as a ball and socket that you have. So you've got lots of motion collectively from those different bones, but it's not as fluid. Certainly there's no true rotation here. We've got a lot of flexion and abduction, adduction. So when you look at this, I want you to appreciate that each of those little carpal bones has around it its own cartilage, has own little ligaments that connect those together. Is it any wonder why we need to have hand specialists, right? Hand surgeon specialists who do nothing but learn about the nerves and the structures and the interaction of these bones within the wrist. As you look at this, you'll see that the ulna is coming down, and that the ulna actually doesn't directly connect with the carpals. There's an extra chunk of cartilage in there, right? So there's not a direct connection, whereas the radius does come down and directly connect to the carpal bones. Next, humeral ulnar and humeral radial. These 2 joints make up what you call the elbow. Humeral ulnar, right, between, now these you know specifically. The humeral ulnar joint is between the trochlear notch, that is the U of the ulna, and the trochlea of the humerus, which is the pulley-shaped structure at the distal end of the humerus. It's also the humeroradial joint, which is the meeting together of the capitulum of the humerus with the rounded head of the radius. Together they come together, and they're going to create a very stable, relatively stable joint. For as much motion as we have, there's a lot of stability here. Not as much movement, right, as the ball and socket joints, because there are some very strong ligaments within the elbow. Again, when we look at the bones, you can't see the ends of the bones because there's so many ligaments holding everything into its proximity. Right underneath this rounded area, what would we call this rounded end of the radius? That perfectly round end of the radius is called the head, right? That's the head of the radius. And the head of the radius is there's going to be a rounded section right here of the humerus called the capitulum. And then the ulna is going to come in with that trochlear notch and connect to the trochlea. I also want to point out that right here it shows us that there's a tendon from a biceps brachii muscle. That tendon for the biceps brachii is attached to what point? Right here. What do we call this point where the biceps brachii muscle attaches to the radius? The radial tuberosity, right? That roughened spot where the radius comes down. Let's look at it from the side, and I'll call out some other things again. So again, we see this, and it's marked. This time it's marked, right? Here is the tendon for the biceps brachii. and it's coming down and inserting onto the radial tuberosity. What would this tendon right here be? It's not labeled. That tendon would be for the antagonistic muscle group. That tendon is for the triceps brachii. Think about it, right? So as you flex your biceps, right, you're pulling the radius and the ulna toward the shoulder. Once you flex your biceps brachii, you're done, right? There's no more power. Your biceps is done. Now to pull your arm back down, you must contract your triceps brachii. So for the triceps brachii to contract and shorten and to pull your arm back down, it must be somehow anchored in the armpit, come around the olecranon, the tip of the elbow, and insert somewhere on the other side, right? So that's exactly what you're seeing. This tendon is part of the triceps, right? Pulling it back around. So this would be the olecranon in here as well, right? The olecranon, and I can't see it, but again, there would be the trochlear notch, right? Meeting up with the trochlea. Now it's all labeled for you. So there's the trochlea labeled for you. The trochlear notch is not labeled, right? Nothing's ever always labeled everything. But there's the trochlea, that rounded part of the ulna, of the humerus, and then the trochlear notch of the ulna. Olecranon, the tip of your elbow, right in here. Coxal joint, your hip. Again, freely moving, ball and socket. It's the head of the femur sitting into the acetabulum of the os coxae. It is stronger than your shoulder, than your glenohumeral. There's a bigger structure because you are carrying your weight on this joint, and allows for all sorts of multi-axial movement. So there's some beautiful bone markings on this to review once again. So let's go through those while we can. So this little button is marked for us. This little button on the femur is the lesser trochanter. The big bump is the greater trochanter. The opening in the os coxa, the obturator foramen. Obturator foramen. The obturator nerve passes down through that. What I cannot see, right? I can't even see the head of the femur, can I? It's hidden back behind the ligaments. Let's look at it a little cleaner. We're actually looking at it now from the posterior side. And there's something on here I definitely want you to see, and that is this roughened area on the ischium. This roughened area is the ischiotuberosity. Which muscle attaches to the ischiotuberosity? There's only 6 you need to know, right? Certainly not the sternocleidomastoid down here. It's not my triceps or biceps brachii. And it's not my gastrocnemius. So there's only 2 muscles in the thigh you need to know more about. You need to know about the biceps femoris and the rectus femoris. If this is your ischiotuberosity or my ischiotuberosity, where is it, right? It's your butt. So what muscle must be attached that you know in the butt? The biceps femoris, right? One of the 3 hamstring muscles. And it attaches up here in that ischiotuberosity area. Again, look at that. There's 6 muscles, right, on that little sheet. Everybody know what I'm talking about? Okay, little stars next to that sheet in your supplement. And look carefully at the origin and insertion markings for those 6 muscles. And if one of those specific structures mentioned is one of our bone markings that you need to know, then highlight it, right? So you'll see that the ischiotuberosity is mentioned for the biceps femoris. And if you look at it from the side, again, from a coronal section, you can see a few other things here. You can see the greater trochanter again here. And now you can see the acetabulum quite nicely. There's even ligaments that are attached to the very head of the femur that hold it into place. So there's so much more structure here than what we appreciate in the lab at this level. Next semester in 106, we will dive into the ligaments, tendons, and muscles involved with the shoulder, the hip, the knee. We'll dive in deeper to these very important joint structures. The knee, again, freely moving. This time a hinge joint. It's actually two articulations. It's the tibiofemoral, the tibia to the femur, and the patellar femoral, the patella to the femur. Now, I told you I wasn't going to add to your knowledge base, but I actually am going to add two ligaments to you. And because these are so commonly talked about, I want you to know what these two ligaments do. The ACL and the PCL. Right, they're in the knee. We turn on the TV, we watch ESPN or something, and we hear about some athlete who suffered an ACL injury, a season-ending injury. So what's going on here? First of all, let's name them. Anterior, A, C, cruciate. Cruciate. What does cruciate mean? Anterior cruciate and posterior cruciate ligament. Cross, right? Crux, cross. So the cruciate ligaments we're going to see in a moment are going to cross over each other. They're going to make an X in the knee. The ACL is in your knee to prevent it from hyperextending. Right? Our knee has a normal range, and these ligaments are there to keep the knee from going beyond its limits. You would never want to hyperextend your knee, right? There's a limit to that. So what sort of motion is going to cause someone to blow out their ACL? Soccer player, football player, something goes on, they get their leg out, some 300-pound guy comes and just lays on their knee and bends it, right, and hyperextends it in a way it shouldn't go, and now their ACL gets snapped. The PCL does the opposite. The PCL limits how much flexion your knee can do. Right? There's only so much flexion your knee should be able to do. There's a limit to that as well. And if you overflex, you could stretch or damage the PCL. Okay? So just know the ACL is preventing your knee from hyperextending, and the PCL is preventing your knee from hyperflexing. What kind of injury, what kind of thing would someone be doing to snap their PCL? Yeah, lifting weights, squatting. I've seen it with kids who are on a teeter-totter, and the other guy gets off, and they got their legs kind of up underneath them, and they come flying. You know, that they come down, or on even on a swing, right? And they've got their leg bent when they land, right? And it over flexes the knee. Now I'll show these to you in a moment. When I first look at this image, though, of the knee, I can't even see. Again, I can't see the bones. But here, what's covering this whole thing up? This guitar pick structure. This is the patella. It's just showing you where it is. So the patella is back behind this. And what's going in front of the patella are the tendons of what muscle group? Coming down the front of the thigh, you've got your quadriceps femoris muscles. And those quadriceps femoris muscles tendons insert, they go over the patella, and they insert into your tibial tuberosity. Right? So that's what's showing right down here. This would be your tibial tuberosity, right in this area, that roughened spot on the tibia to which these quadriceps femoris muscles attach. Which of the four quadriceps do you need to know specifically? The rectus femoris, right? That was one of your six. So the rectus femoris comes around, as do the other muscles, and attach. You see there's also a bursa in the knee that is protecting, giving a gel pack kind of structure. Let's look at it from the side. So I know in the lab when we laid out the femurs and the tibia, and then we had the patella, and we kind of stuck the patella there, you know, where they came together. It wasn't really an accurate place where we put it, but it rested there. The patella only makes contact with the femur. So you can see right there, there's a little patella, and there it is coming in contact with the femur. It does not come in contact with the tibia at all. Okay, so it's kind of hanging out there. And what's additional, though, in your knee is that there's two chunks of cartilage. right? Two big angular chunks of cartilage called your menisci, or each one's a meniscus. There's a lateral and a medial meniscus. And that meniscus is made up of fibrocartilage, very tough, shock-absorbing kinds of cartilage. And it's taking the weight of your weight, all the time, being banged on as you run and walk. And that cartilage is what is so famously damaged, right? When someone has to have their knee replaced, either that meniscus, that big chunk of cartilage has been damaged and misshaped, or maybe the articulating cartilage has worn down and now the person is got bone on bone, right? Very, very painful. And then they put in a prosthetic knee or something. Now, let's look at that ACL and PCL in this image. This is the anterior view of the knee. So that means, and I can kind of tell, because I'm looking at this spot right there, and that would be what again? That bump right there is the tibial tuberosity. So this is the anterior view, and here I see a crisscrossing structure. So the one in the front, anterior cruciate ligament. The one behind it, posterior cruciate ligament. Now there are other ligaments that hold your knee together, and we'll deal with those next semester. But I do want you this semester not to label. I'm not going to say which one's which on a picture. But I do want you to know mentally, ACL preventing hyperextension, PCL stopping hyperflexion of the knee. Looking at it from the backside, okay, we're looking at the posterior view now of the knee, and this big chunk of cartilage is sitting on that big rounded structure. What are those big rounded knobs on the distal end of the femur called? Big rounded articulating knobs, a condyle, right? So those big condyles, we saw the occipital condyles as well. There are condyles all over the skeleton. And then what's on each side of the condyles? Bumps on either side of the condyles are called the epicondyles, okay? And guess what's attaching to those? Ligaments, okay? We'll come back to it next semester, but there are little ligaments that attach to those little side structures. Now, this is your anterior cruciate ligament there in the front, and then on the back, here's part of your posterior coming down. Again, I'm not going to ask you to label them, right? Just know that they cross over each other, and you can see them pretty clearly on the images. Last one, I believe, talocrural joint, right? Between your talus, the tarsal on the top of your foot that you know about, and your crural region, which is your leg. So this is actually the tibia and the talus coming together, as well as a part of the fibula coming down to the talus. This joint is what allows you to dorsiflex and to plantar flex. So the motion of the ankle, right? The dorsiflexion and the plantar flexion motions. And when I look at this picture, I'm always amazed at the complexity also of the foot. I mean, no wonder we have people who do nothing more than go to school for 4 years to become podiatrists. And they work exclusively on foot issues. Look at the complexity here. All those bones, all those little ligaments, all connecting and not only connecting to each other, but supporting the entire weight of your body. Right? So all of that structure. Now, in this image, what's important? The heel bone, you're going to call that the calcaneus, right? And then the rounded bone on the top of the foot is the talus. The fibula comes down, and there's a bump on the fibula. Remember, the fibula is more lateral. So what bump is found on the side of your ankle associated with the fibula? The lateral malleolus. Okay? Then the tibia is providing the bump on the other side, the medial malleolus. So we can see the malleoli a little bit better here. So this bump coming down from the fibula, right, there would be your lateral malleolus, and over here the medial malleolus. You can even see the ligaments attaching the tibia to the fibula down here, can't you? Some of those stabilizing fibrous joint type structures. Has anyone ever suffered from plantar fasciitis? Okay, so describe to me what's going on when you have that.
It's in my heel. 'Cause I ran track and cross country, so it would just hurt
Right. So every time you'd stand up and walk again, it would really hurt, right? Getting up out of bed or getting up now to walk. Yep. And what's happening is that this ligament that's going up along the arch of the foot is getting stretched, right? And every time you walk, it's stretching. And it can be very, very painful. Sometimes they'll actually have to go in and surgically cut that if it just can't be resolved. They'll put arches in the shoe and do all sorts of things to try to keep that arch up and not allow it to collapse. Because every time you're putting a lot of weight down, it can stretch that ligament. Now, this ligament will also stretch during pregnancy. Not to get too nosy, but any moms in here, and did your shoe size change after pregnancy? A little bit? Did you get bigger feet? Okay. And it's not just because the baby weighed you down and you stretched out your feet. During pregnancy, toward the end, hormones are released that soften ligaments. And really the ligament that you're trying to soften is the pubic symphysis. Right? That cartilage there gets softer so that during birth, the birth canal and the pelvic area gets larger, right? You can give birth if that pubic symphysis is squishy. Well, the same hormone that softens that pubic symphysis is also softening these ligaments across the bottom of the foot. So they get a little softer, and as a result, the foot elongates a little bit. Okay, so that is just a run through about 6 or 7 main joints. Your take-home lesson from those is name that joint, know where in the body it is and what bones are involved, and be able to identify any bone markings that are associated with it that we already talked about. Nothing new, nothing extra. They're all freely moving synovial joints, and the only thing extra in that conversation was ACL and PCL, right? That was the only thing new. Any thoughts or questions related to TMJ through talocrural joint?
You said those soften up during pregnancy. Do they harden back?
Not completely. So once stretched, they kind of stay stretched. Yeah. So they elongate a little bit, and then they don't rubber band back. Yeah.
When you tear ligaments, why does icing help?
Why does icing help? Well, you're helping with the inflammation. So as you tear, as you pull on a tendon or a ligament, either one, keep in mind they're dense, regular connective tissue. Really what you have are collagen fibers densely packed with some fibroblasts. Almost avascular, right? I mean, they're pure white, right? Tendons and ligaments, you see them, they're white just like cartilage. There's just enough blood flow to keep those fibroblasts alive, but not a whole lot. So they don't heal very well. But as you pull, right, on a tendon or a ligament, you're definitely also affecting the muscle and the soft tissue around it. So the icing is just to help with the inflammation and keep that inflammation down, because the last thing you want this thing to heal, right? You stretched it, you want it to heal, so you want to stop the muscle contraction and the soft tissue damage and keep it from expanding. So anything that's warm, right, is going to elongate. Anything that's cold is going to kind of shrink, and you're going to also reduce the swelling. So it's really more about swelling than it is anything else as far as repair. So ligaments and tendons just tend to heal very, very slowly and are never quite the same. Never quite the same. Because what you've done is you've torn those collagen fibers away from each other, and once it's broken, it can't be repaired completely. Any other questions on joints? Okay. Last time I mentioned in the bone lecture a little bit about how bones break, right? You know that bones have a lot of blood in them. So when a bone breaks, it's going to make a big hematoma, a big clot of blood. And then those osteoclasts, those chewing cells, are going to come in and kind of clean up the debris and get rid of that blood clot. And then the osteoblasts that are around the periosteum or on the outside edge are going to start making bone. And the first bone they're going to make is spongy bone. And then that spongy bone is going to be replaced by compact bone. And so after a few months, 6 to 8 weeks, the bone has reformed enough that you can now walk on it again, right? If you damaged a bone. And now that bone's still not completely healed, right? It's going to be it could be 2 more years before that bone has reached its final healing moment. But after 6 or 8 weeks, the bone is healed well enough on its own to allow you to put weight back on it or take the cast off. Now, how bones break. Let me just go through a couple different types of fractures. Simple. Simple fracture. It doesn't necessarily mean that it's going to be a simple fix, but simple here means that the skin was not broken. So the bone broke completely within the body. It did not come sticking out. A compound fracture does not necessarily mean that it's any more difficult to repair, but it means that the bone stuck out of the skin. So it's a much more traumatic injury. There's compounding issues, I guess you could think of, as far as the skin being broken. And then there are green stick fractures. Another word for green stick fracture is an incomplete fracture. So it's like you're going camping and you're going out to get some kindling. You want to start the fire. And the wood you want to go find is that nice brown, dead, snappy kind of twig. And if you go and get a green stick, right, and you try to snap it, it's not going to snap. It's just going to bend, right? So that's where this gets its name. A green stick fracture is an incomplete fracture. It may break on one side, but the other side doesn't snap. Okay, so I'll show you a picture of this. So on the far left-hand side, this is representing a simple fracture. You can see that the bone, the tibia, has been broken. There's a fracture here, but it did not break through the skin. Simple fracture of the tibia. On the middle picture, however, you can see that the tibia has gotten rather sharp and broke out through the skin. That would now be a compound fracture. They're both probably going to just require those bones to be realigned. It might require a pin for both of them. Who knows, a plate or a pin, whatever the orthopedic surgeon decides. But they're going to heal back together quite nicely. Over here on the right-hand side, you can see the green stick idea. Right here on the lateral side, you can see that it didn't break all the way through. Right? So it's an incomplete fracture. You can see the fracture here, but you don't see it going all the way through. So green stick fracture. Now we can also use the angle of the damage to describe fractures. So there's transverse fractures, very easy. Just means that it went, cross-section or transverse. Spiral fractures. Now if you go into the ER and you have a spiral fracture, especially as a young child, you're probably going to raise the interest of the emergency room staff and probably going to see a social worker knocking on the door. A spiral fracture is gotten when someone falls and breaks the bone while in a twisting motion. Now it's easy to imagine for a basketball player who's up and doing a layup and a spin motion, and they come down and get a spiral fracture, or for a gymnast who's twisting as she or he lands. But a spiral fracture is also what is seen in child abuse situations, where a person has twisted the kid's arm and broken it. And that spiraling action, right, is causing a spiral fracture. So a spiral fracture is typically a sign, right, that there could be some abuse going on, so you'll get some more attention in the emergency room. Oblique is going to be any sort of break at an angle, okay, an oblique angle. And then finally, comminuted simply means that the bone didn't break into just two pieces, but three or more pieces. So it gets shattered, or there are many little fragments involved. That would be a comminuted break. So let's take a look at some of these different examples. So here, on the far left, there's a complete fracture, and over here would be the incomplete fracture, or a green stick, right? Green stick. Here's comminuted, where you see multiple pieces. This is probably not going to heal all on its own. You'd have to put some plate in there or something to hold all those fragments together. In fact, they may have to take those fragments out surgically and then put a rod in there. On the far right-hand side, you see the oblique, right, the angle of that slice here. And then here is the spiral. You can appreciate that that bone is kind of broken and kind of spiral staircases up and around. One I didn't mention yet is, here's transverse, straight across. And then here's an impact. And this would be common, falling off a ladder straight down, or maybe you're driving in a car and there's front-end trauma to the car accident and your hip, boom, the head of the femur is pushed up into the os coxa. And here you can see that the whole neck of the femur has basically been broken, right? There's an impact kind of fracture. So let's use these words now to describe these fractures. So what two words can I use to describe this fracture on the left? Not only is it simple, but it's also transverse. Simple enough, right? This one in the middle, not only is it compound because it's coming out of the skin, but it's also oblique. That easy, right? So 2 words to describe those fractures. Here's another, an x-ray, color-enhanced x-ray of a hip fracture, and you can still see the head of the femur. It's fine. So the head's fine, the acetabulum in which it fits, the neck. Here, actually, is part of the greater trochanter that broke off, isn't it? Okay, and created this hip fracture. So speaking of fractures, who is breaking their bones? And this is just total common sense. So people who are under 65, right? As a group, these individuals are, breaking a lot of arms and legs. They're doing all kinds of crazy things. They're not breaking, however, very many hips, right? You don't see many younger people with broken hips. And they're out doing downhill skiing and crazy things, so you'll see more skull fractures, head injuries. People over 65, they're not doing as much downhill skiing, so not as many skull fractures, but you see a large number of the hip fractures go up, in part because of osteoporosis that we'll talk about in a second, and aging phenomena that happen with the bones. Also, while they're falling, right, they're also breaking a lot of arms and legs because they're reaching out to break that fall. So they're snapping arms and legs and ankles as they do that as well. This slide is my reminder to remind you that we learn these systems in isolation, right? We're learning the skeletal system last time. Today we're talking about joints, which is also part of the skeletal system. Next time we'll deal with the muscular system, and then we'll move on to the nervous system. But we can't lose sight that these systems are interrelated, right? That all these systems are talking to each other, if you will, and that they're interacting in very sophisticated ways. So as we look at this slide, it reminds us that the skeletal system is directly interreacting or relating with the integumentary system. Well, one way, remember that bones need vitamin D, and that it's the skin that helps produce the vitamin D, so we've got a connection between the skin and bones. This one's obvious. The bones connect to the muscles to allow movement of our skeleton. You know that there are nerves, right, going through your bones, so there's a connection there, but don't forget, too, that the skull protects your brain, and the vertebra protect your spinal cord, so there's a connection between bones and the nervous system. I mentioned last time parathyroid hormone and calcitonin, 2 hormones that are involved with calcium regulation and therefore bone well-being. So the endocrine system has a connection to the bones. The bones are making your blood cells, so there's a connection with the cardiovascular system. And your lymphatic system has a lot to do with your immune system. And remember, your white blood cells are part of that immune system and are also made inside your bones. I mentioned that the digestive system could be coaxed, if you will, into absorbing more or less calcium based upon hormone levels. You've got the ribs working. Every time you breathe, your ribs are expanding. And also, of course, your ribs are protecting your lungs. I told you that by hormonal control, also, your kidneys are either capturing or allowing more calcium to be released that are important for bones. And clearly, the reproductive organs are partially protected by the os coxa and the pelvic bones. So you see that there are these connections, right? And on the test, I will ask you to name 2 of these connections. It'll be very straightforward. And this will be a very small, short answer portion on the exam. And I'll say the skeletal system interacts with what other system? Blank. And tell me specifically, describe for me that interaction. It doesn't have to be really, really fancy, but it has to be at least thinking of outside of just the skeletal system and how this system interacts with others. I'll also have a similar question related to muscles. So how is the muscular system interacting with other systems? And you'll see that question on every exam I give between now and the end of the course. So I'll try to remind you of it, but this is my reminder to be thinking about these interrelated spots, how one system interacts with another. Does that make sense? Okay. I just don't want us to think completely in little bubbles and then forget the big picture. Every semester I have students who leave that blank and they'll tell me, man, I forgot. I can't think of any connection at all. Whew. we're really tired if we can't think of how the brain is protecting, the bones of the brain, the bones are protecting the brain, right? That's not hard to think about. So just think about a couple different connections, the skeletal system to all the other systems. So there'll be two, on the test, there'll be 2 skeletal and 2 muscular. 2 skeletal and 2 muscular connections. I also try to leave us thinking about the joys of aging, right? As we go through each of these systems, what can we look forward to as our system gets older? And the skeletal system, as it ages, starts to experience osteopenia. That's just a fancy way of saying deficiency in bone. The bones get a little weaker, they become thinner, they're more likely to break, they become less ossified and demineralized, meaning they lose some of that calcium and phosphate deposit. The mass decreases, and sometimes that is referred to as osteoporosis, when the size of the spaces becomes more porous. And osteoporosis is happening not in the compact bone on the outside, but osteoporosis is mostly on the spongy bone on the inside. Now, where this erosion and changing of the bones is most dramatic is in the vertebra, right? People get a little bit shorter with age. The vertebra get, the body and the little intervertebral disc gets a little bit thinner. So I know I'm about an inch shorter than I used to be, right? If every one of those discs loses just a little bit, a little millimeter, right? 24 times 1 millimeter, that's a centimeter, right? That's an inch. So 24 millimeters is an inch. So you can easily lose an inch of height from just a little bit of that cartilage degrading between each of the vertebrae. The jaw bones also start having some changes, and that leads to looser teeth, right? So the teeth become looser, the gomphosis is interrupted. And our bones also become more fragile and more brittle, so that when we fall, we're more prone to break the bone. My mother-in-law, love her to death, so when my kids go down to Florida to visit, there's a skating rink, an indoor skating rink just down the street. And they'll go out ice skating, and she loves going out and ice skating with the kids. She's in her 70s, but she doesn't want to become a statistic. And as odd as it looks, she will literally take a bedroom pillow and strap it with duct tape around her butt. She doesn't care, right? She's going to go skating. She's going to enjoy herself, but if she falls on her butt, she's not going to break her hip. So she'll put this big old pillow around her butt and put a jacket over it, and it just looks like, something a little different. And but she's protected, and she feels like she's having a good time, and the kids laugh at her, but they're having a great time. So that is, that's a statistic that's real, that as we get older, our bones will get thinner and will be more prone to fracture. What do we do to maintain that? What do we do to minimize that? Remember I talked about good vitamins, supplements, right? Calcium and vitamin A and vitamin D, and staying active, keeping some weight-bearing activities on your bones will keep them healthier as well. As we get older, the articulating surfaces will begin to deteriorate. That is, the cartilage can begin to deteriorate. That can put bone on bone. Remember, cartilage doesn't recover. It doesn't really come back once it's worn down. Nowadays, we're putting in pieces of cartilage from cadavers into people's knees, right? So we'll take that piece of meniscus, that big chunk of cartilage out of a cadaver. Remember, cartilage is avascular. There's no blood flow. So a big deal, sticking a piece of cartilage into someone's knee, they're not going to have a lot of immunoreaction because there's no real blood flow. I also, this, but remind you that the skeletal changes are not just with age, but the constant change throughout time. So children have a lot of skeletal changes as well. Calcium becomes a big issue by age 35 for women and for men by age 45. So really be talking with your doctor about supplements of calcium to minimize some of this osteopenia. This is a picture, 2 electron micrographs side by side, put together by I forget which pharmaceutical company, and it's very misleading. On the left is what your spongy bone looks like, right? That trabeculae, that kind of mazy-looking structure within spongy bone. And on the right, what they're trying to do is show you how much bigger those pores get with osteoporosis. But the more discriminating eye notices that they change the magnification. So they went from 20x to 30x. So of course those holes look bigger. right? But the point is this, is that there are medications that will stop or at least slow down this progression. All of these medications, Fosamax, Actonel, Aredia, Boniva, there's a bunch of them out there, all do different things, but they all work on osteoclasts, right? So they're decreasing, in part, the activity of those chewing cells. So that means that osteoclasts kind of get shut down. Now what issues might these people have? What's going to get low? If I can't chew up my bone like I'm supposed to with my osteoclasts, that means I can't release calcium as I need it. So anybody on one of these meds would also probably be having issues with low calcium, and that could now trigger issues with their parathyroid gland because they're having to always put out parathyroid hormone to make up for that low calcium. So you can see that, you know, one medication meant to do one thing can have dominoing effects on other systems. Arthritis, right? We're talking about joints here. Inflammation of the joint spaces. Now, arthritis is not a single disease or even two. There's actually over 100 diseases which are part of the arthritis family because in some way the joints are inflamed, right? Arth, joint, itis, inflammation. In two of these x-rays, in the upper right and the lower left, you can appreciate how deformed that hand is, right? There's such an inflammation of the joints, and these two images on the top and the bottom, those would be of rheumatoid arthritis, the kind of arthritis where it's very, very deforming to especially the hands, stiffness, swelling. On the lower right, here you've got the femur coming down to the tibia, and this space should be nice and smooth, right? You want a nice, smooth joint space in a x-ray. And in this x-ray, it looks like there's a little bit of crunchiness right about there. It looks like there's bone on bone. So this person could be getting this x-ray because they're complaining to their doctor, man, when I walk, it's hurting. I've got some bone on bone issues. But I also want to mention that this x-ray reminds me to tell you that we don't treat x-rays, right? Physicians treat patients. So a patient may walk in and have an x-ray done, and the x-ray looks horrible. It looks like they should barely be able to walk. But they're like, I don't have any real problems, right? And other patients will have an x-ray, and the x-ray looks relatively okay, minor, but they're excruciating pain. So again, we don't treat the picture, right? We don't treat the x-ray, we treat the patient based upon their symptoms. So here you can really see that disfiguring hand on the upper picture, and here's her x-ray down below, and you can just see that the joints are so inflamed that her little phalanges, right, are just kind of completely out of whack. So imagine how painful that would be, right? Now this is rheumatoid arthritis, and rheumatoid arthritis is one of many. I'll show you in a moment that rheumatoid arthritis is the type that affects women more often than men, and it's considered an autoimmune disease. So the body's actually attacking itself and causing that inflammation. Arthritis is on the rise, in part maybe through better diagnosis, in part because we do have an aging population. And as we grow older, you know, likely our joints will suffer with that. And so these numbers are a little bit old, but you can see that there's a straight up trajectory on the percentage of the population who are going to be dealing with arthritis. It's a major issue, major chronic health condition. It doesn't go away. Once you have arthritis, it's not going to go away. You're just going to be dealing with the symptoms and trying to manage it better. Because once you start breaking down the cartilage, it's not going to get better. Now, some of these other conditions you might be able to specifically treat. It's the #1 leading cause of disability for folks over 15, and it isn't just an old folks disease. There are types of arthritis that affect kids. There are types of arthritis that affect middle age. Think fibromyalgia, lupus, scleroderma. Those are all conditions that affect joints, so they're also part of the arthritis family. Okay, and we hear about fibromyalgia and lupus and scleroderma in the news sometimes. Okay, so I do want you to know these two types specifically. The other ones I'm not going to ask you about, but I do want you to know the difference between osteoarthritis and rheumatoid arthritis. Osteoarthritis, as the name suggests, bone, joint, right? So this is where there's inflammation and bone is sitting on bone. It doesn't discriminate male or females. It's more just a general bone on cartilage issue that can happen to all of us with age. Rheumatoid arthritis is it is definitely the autoimmune disease and definitely affects women far more than men. Okay, and that's also true of scleroderma and of fibromyalgia. Those are also lupus. Those are all part of this autoimmune disease complex that we don't completely understand, but definitely affect women more than men. There are, however, some forms of arthritis that affect men more, and one of those is gout. Gout definitely hits guys more than women, and gout usually attacks the big toe. So some of these forms of arthritis are very, very specific as to where in the body they affect. Other forms of arthritis only affect, for example, the spine. Ankylosing spondylitis. Don't memorize it, don't learn how to write it, but some only affect the spine. And then I've mentioned lupus and fibromyalgia and scleroderma. These are all, because they somehow attack the connective tissue and the joints, are considered an arthritic form, right? A form of arthritis. I've got 3 minutes to share with you just a couple more things about joints and some malformations that can occur. So we know this term dactyly, right? Fingers, digits, toes. So some individuals will be born with polydactyly. That means they would have more than 5 fingers or digits. So I can see in the picture, this guy up here could play piano pieces that most of us couldn't, right? We got some extra fingers, right? So that'd be polydactyly. Then in this image, I can see that this little guy has a 6th toe, but I also see that it's fused, right? The 5th and 6th toe are fused together, and that brings us over to the next term, and that is syndactyly. So that's where you've got a fusion of the fingers, sorry. So you can see here where the fingers are fused together. Now, what process did not occur properly during development if they have syndactyly? Apoptosis, right? The idea that programmed cell death. So as the hands were being formed between the 5th and the 10th week of human development, remember that picture I showed you? 5, 6, 7, 8, 9, 10? And during that time, the hand goes from being a paddle to having distinct fingers. And apoptosis, cellular death occurs to separate those fingers. So it didn't go right. Something didn't go right. And then there's also ectrodactyly, which is this claw hand, lobster hand type of motif. So just different versions of limb malformations. Now, I told you that because I want to tell you about this one specific type of limb malformation that was relatively common back in the late 50s and early 60s. It's referred to as amelia, which is a loss of a functional limb. And I remember that easily because I'm sure Amelia Earhart suffered from amelia. It's horrible, right? When she fell out of the sky, I'm sure she lost a limb. So amelia, right? Amelia, loss of a limb. Focal amelia is some sort of flipper-like limb. So this little baby has focal amelia, and you see flipper-like arms, flipper-like legs, and also some malformations of those extremities. And his little hands even are actrodactyly. So you see the ectrodactyly. You see the claw hand on this little guy. Now, what caused this birth defect is a drug called thalidomide. Thalidomide was given to women who were pregnant for nausea. And nausea is usually between the 6th and the 12th week of pregnancy, right? It's early. Now, what's happening during 6 to 12 weeks is also during that time when the hand's being formed and the limbs are being formed. And this drug, unknowingly, was given to women for nausea, but these kids were being born with focal amelia, with no limbs, improper limbs. And they finally figured out that this drug was a teratogen. That means it causes birth defects. And it was blocking angiogenesis. And we know what that means. Genesis, formation of, angio, blood vessels. So the blood vessels were not able to properly form, and therefore they did not get proper arm or limb production. Now, the other lesson we learned from this is that this drug had been tested on mice and rabbits. It had gone through, up until the 50s and 60s, research was done on animals, but not on humans very much. It's very, very expensive, as you know, probably to get a drug to market. Billions of dollars to get a drug to market because now we're forced to go through clinical trials with humans. So up until this time, they tested this on rabbits and mice, and there were never any birth defects on rabbits or mice. And this was our first big wake-up call, or one of them, that said, you know what? Mice and rabbits aren't just little humans, right? They have different phenomena. So it didn't cause any problems in those little rodents, but it did cause problems in humans. This drug is back. It's being used again, not for nausea, but it is being used in some chemotherapy cocktails. So what do tumors do? Tumors have a way of making their own blood supply. They have their own way of getting their own vascular angiogenesis. So if we add dalilimide to a cocktail of chemo drugs and it can knock out the ability of the tumor to make new blood vessels, then hopefully we can reduce the spread and the taking hold of that tumor. Okay, so just know thalidomide causes these issues, and this was back in the 50s and 60s when we discovered this drug, did this. So that finishes up this presentation on joints, and what was left for us next Tuesday will be over muscles. The last little bit, I never quite get all the way through the muscle presentation, so it looks longer than it's going to be. And wherever I get through on Monday or Tuesday is where we'll stop the exam. And then the exam will be the following Thursday. Now, a week from today. In preparation, remember you got your mastering assignments. There's one that's over bones, and there's one that's over joints. So you can easily now do 2 of the homework assignments. You got all the information you need. The third one on muscles you may want to wait on, but you might want to at least look at it. Remember, I have copies of the homework. You don't have to do the copies. They're just there for backup if you want to do them again. And I also have a quiz that I'll tell you about again next Tuesday that'll be due by Wednesday at midnight that will help you get prepared for the exam. So come see me if you have any concerns. Otherwise, I will see you all next Tuesday.